Extract 1. Questions 1 to 12.
In this task, you'll hear a physiotherapist talking to a patient called Ryan Henderson. Answer the questions below by completing the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Ryan Henderson? Please come in and take a seat. My name's Kathy. I understand from your GP that you've got a problem with your knee.
Oh, hi there. Yeah, that's right. It's just the left knee, just below the kneecap. It started about 4 weeks ago. I first noticed it when I'd go for a run. I'd get this sort of niggling pain, which would get increasingly worse. It's gotten to the point where sometimes I even have to cut my run short.
Does anything else seem to aggravate it?
Yeah, actually, going from when I'm sitting and then standing, or when I'm sitting at a desk with my knee bent, I really feel the pain then. It's not very sore at the moment, but it seems to be getting worse as the day goes on. It doesn't wake me up when I'm sleeping or anything like that, but it seems to go away during the night, and I suppose that's why it feels better in the mornings.
Okay. Do you have any other symptoms like pins and needles or numbness in your knee?
No, nothing like that.
Do you have any history of injuries or accidents that might account for the pain?
Well, I cut my left knee pretty badly climbing over a concrete wall when I was younger, but that was about 15 years ago or more, so I don't think that would have anything to do with this. It gave me a pretty crazy scar though.
Ah, I see.
Other than that, I've just had your typical sorts of injuries. I broke the little toe in my left foot playing football when I was about 10. Ever since then, I've had to wear shoes a size larger. Then, when I was about 25, I twisted my right ankle playing squash and ended up breaking a small bone just here, what's it called? Is it the fibula?
Ah, yes, that's right.
Okay, but it's been fine. Haven't had any problems with it since. Then just last year, I broke the little finger on my right hand playing rugby. Totally unexpected that was. And I almost forgot I've had this bursitis in my left hip.
And when was that?
Last year, I saw one of your colleagues actually for some physio treatment, and they said to take a break from running for 6 months, which I did. I did a lot of stretching and I started doing yoga twice a week. It seemed to help, so I was able to start running again after Christmas.
And is the bursitis better now?
Yep, there's no pain in the hip. Now it's the darn knee that's giving me grief.
Yeah, well, can I just get you to stand for me and put your full weight on your left leg?
Yeah, sure.
Tell me, how does that feel? Any pain or discomfort?
Yeah, I can feel it is a bit niggly just at the front of the kneecap, and I do feel a bit of pain.
And if you do like a little half squat, bend your knees and come back up. What's that like?
Oh, ow. I can feel a bit of pain in both knees actually. More in my left knee, like a sharp pain, but there's definitely a little ache in that right knee now as well. I'll just try standing on my left leg again and see what that's like. Oh, that really hurts.
A lot worse?
Definitely.
Okay. Can you sit on the side of the bed and I'm just going to test the muscle strength. I want you to push your right leg out against me as hard as you can go. Is that okay?
Yeah, okay. It's harder to do with my left leg though. Like it's weaker or something. Like I can't get enough power through it. That's really strange. I hadn't realised it was that weak before.
Well, Ryan, I think I know what's going on with your knee. It appears that your kneecap is a little bit out of alignment.
Oh, wow, okay. And how does that happen?
It can occur because the ligament, which we call the iliotibial band, it's gotten a bit too tight on the outside of your thigh. And in your case, I can see that there is some minor swelling on the outside of your left knee, which means there's some underlying inflammation there.
I guess that explains the pain then. Seems like my days of pounding the pavement might be over. I might have to find some other way of getting my exercise. That's really disappointing. I've been into running since I was in secondary school. Used to be on the cross-country team and everything. But now it seems like every time I lace up, I get problems.
Extract 2. Questions 13 to 24.
You hear a neurologist talking to a new patient called Sylvia Gunn. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mrs. Gunn. You've been referred to me because of some pain in your face. Now, I've got some notes from your GP, but perhaps you can tell me in your own words about the pain, when it started, and what's happened since?
Well, it began about 3 years back. Out of the blue, I got this terrible shooting pain in a back tooth. I've never felt anything like it before in my life. It was a tooth I'd had a nasty abscess on a few years before, and I assumed that it had got infected again. Anyway, I went off to the dentist as soon as I could get an appointment. So he did some x-rays, but he couldn't find anything wrong, which was very strange.
Was the pain continuous, and did anything in particular trigger it?
It came and went, and it lasted just a minute or so each time, but it really got bad when I brushed my teeth. I always use an electric toothbrush. They're so much better than the usual sort, but I didn't like that one little bit. I even tried to persuade the dentist to whip the tooth out there and then, because I was so sure that that was the problem. But he told me he was pretty sure there was nothing wrong with my teeth at all, and I ought to see my GP.
And your GP has diagnosed trigeminal neuralgia?
Well, first of all, the GP told me to try painkillers. That was to exclude things like a migraine, I think, but the pills, they didn't have any effect at all. So then he sent me off for a CT scan because he said it might be a very bad case of sinusitis. I'd had that before when I was a teenager. Or he said even nerve damage, but that was all negative too. So then after all that, the GP eventually put me on an anti-epilepsy drug, which seemed to help.
I see. So how is it now?
Well, the pain sometimes goes away for weeks at a time, but then it can come back a dozen times a day. Fortunately, I get a tingling feeling in my jaw when it's going to start, which I can recognize as a sign, so at least I get a bit of warning before the pain comes on properly, and I can try to find somewhere quiet to sit down.
But the pain has now begun to spread?
Yes. It started to happen in my eye, too, on the same side as the tooth. I was doing okay until the firm where I work moved to a new office. It's a lovely new building, and everything was fine at first until about 3 months ago when the weather started to improve and they turned up the air conditioning because lots of people were complaining about being too hot. That's when I started getting pains in the eye, and I'm pretty sure it's connected. But the system's the same all over the building, and it's not as if I'm sitting in a draft, so there's not much I can do about it. I've tried wearing glasses all the time, and that seemed to help a bit, at least at the beginning.
And these pains in the eye, tell me how long they last and how often you get them.
It's getting worse and worse. Over the last fortnight, it's been every day, and sometimes every hour, and it's really excruciating. It's getting me down, and I've started losing weight too, what with the worry and the pain, and I've had to give up my yoga class, which I loved, because you never know when the pain's going to come on. And, well, that's making me feel very isolated. I really hope you can do something more for me, Doctor.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which best fits according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at question 25. You hear a discussion between a physician and nurse explaining about schistosomiasis and its causes. Now read the question.
Hello, doctor. What is schistosomiasis, and what are its causes?
Schistosomiasis, also termed as bilharzia, is caused by parasitic worms. Although these worms are not found in the U.S., more than 200 million people are affected worldwide by this disease. In terms of impact, this disease stands next to malaria as the most devastating parasitic disease. Schistosomiasis is also considered one of the neglected tropical diseases. The parasites causing schistosomiasis dwell in certain types of freshwater snails. The infectious form of the parasite, known as Cercariae, emerge from the snail, therefore contaminating water. Most human infections are caused by Schistosoma mansoni, S. japonicum, or S. hematobium. One can become infected when the skin is exposed to contaminated fresh water. Question 26. You hear a discussion between 2 doctors about the importance of measuring serum amylase or serum lipase. Now read the question.
Doctor, can you explain to me whether measuring serum amylase or serum lipase is significant for acute pancreatitis?
Well, measuring both serum lipase and serum amylase is not necessary. Measuring serum lipase alone is adequate for diagnosing acute pancreatitis, since it is more effective than serum amylase, especially because it rises more quickly and remains elevated longer. According to a study of 151 patients with acute pancreatitis, the sensitivity of lipase was about 97% and the specificity was almost 100%. Contrarily, the sensitivity of amylase was just 79% and the specificity was 99%. Therefore, amylase should be replaced by lipase as the first-line laboratory investigation for suspected acute pancreatitis. Question 27. You hear a discussion between 2 doctors about the misdiagnosing of acute cardiorenal syndrome as renal injury due to hypovolemia. Now, read the question.
Hello, doctor. What is your opinion about misdiagnosing of acute cardiorenal syndrome as renal injury due to hypovolemia?
Often, acute cardiorenal syndrome is misdiagnosed for renal injury due to hypovolemia. Patients with stable heart failure normally have mild hypervolemia at baseline. However, they can become hypovolemic due to severe diarrhea, over-aggressive diuretic therapy, or other causes. Although the fluid status of these two conditions are different, they are often difficult to distinguish. Urine electrolytes suggest a pre-renal acute kidney injury in both of these conditions. However, a history of recent diuretic overuse or recent fluid losses may help identify hypovolemia. If available, analyzing of the recent trend in weight will be essential in making the right diagnosis. Misdiagnosis of acute cardiorenal syndrome as hypovolemia-induced acute kidney injury will be catastrophic. In case the volume depletion in acute cardiorenal syndrome is erroneously judged to be the cause of acute renal injury. Therefore, fluid administration can further worsen both renal and cardiac function. Question 28. You hear a physician explaining to his nurse about sepsis and infection. Now read the question.
Doctor, what is sepsis?
Sepsis is the extreme response from our body to an infection. This is a life-threatening condition, and without timely treatment, sepsis can rapidly cause tissue damage, organ failure, and mortality. This happens when an individual already has an infection in his lungs, skin, urinary tract, or somewhere else, triggering a chain reaction throughout the body. 4 types of infection that are often connected with sepsis are lungs, kidney, skin and gut, and the most frequently identified germs that cause infections and can develop into sepsis include Staphylococcus aureus or staph, Escherichia coli, and certain types of Streptococcus. An infection occurs when germs enter into the body and multiply, causing illness, organ and tissue damage, or disease. In case that infection grows aggressively resulting in a life-threatening condition is called sepsis. Question 29. You hear a discussion between 2 doctors about brain imaging prior to lumbar puncture in the suspected cases of bacterial meningitis. Now read the question.
Hello, doctor. Can you please explain to me when the brain should start the imaging precede lumbar puncture in the suspected cases of bacterial meningitis?
For the patients with immunodeficiency or focal neurologic deficits, or with altered mental status or seizures in the past 7 days, a brain imaging should be performed prior to lumbar puncture. Moreover, corticosteroid therapy and empiric antibiotics should be started immediately after lumbar puncture without waiting for the results. Brain imaging should precede lumbar puncture in patients with focal neurologic deficits or immunodeficiency, or with altered mental status or seizures during the previous week. However, lumbar puncture can be safely done in most patients without first obtaining brain imaging. In case the lumbar puncture is to be delayed, then these treatments should be started immediately after obtaining the blood culture report. Question 30. You hear a monologue by a physician about managing aneurysmal subarachnoid hemorrhage. Now read the question. Managing aneurysmal subarachnoid hemorrhage. Patients with aneurysmal subarachnoid hemorrhage are at high risk of complications such as delayed cerebral ischemia, rebleeding, cerebral infarction, and mortality. The main symptom is the abrupt onset of severe headaches. When this condition is suspected, a tomography without contrast should be performed. However, positive outcomes are seen when patients are managed in a high-volume center with a specialized neurointensive care unit. Early aneurysm repair by surgical clipping or endovascular coiling is the best strategy to reduce the risk of rebleeding. Medical and neurologic complications such as increased intracranial pressure, hydrocephalus, seizures, hyponatremia, delayed cerebral ischemia, hypovolemia, and cardiac and pulmonary abnormalities are extremely common.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C which fits best, according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear an interview with a scrub nurse called Joanna Swan. You now have 90 seconds to read questions 31 to 36.
Today, I'm talking to Joanna Swan, who works as a scrub nurse in the operating theatre. Joanna, firstly, remind us what a scrub nurse is exactly and where the name comes from.
Sure. Well, perioperative nurse is the correct term, of course, but basically we're all familiar with the notion of scrubbing in. You know, you've seen surgeons doing it. It's not just washing your hands, it's doing that very thorough cleaning to ensure you're completely sterile before you go anywhere near the patient or the surgical instruments.
Mm-hmm.
But the name scrub nurse doesn't quite capture the full role. I mean, basically, your job's to prepare the operating room for surgery. You lay out the instruments, hand them to the surgeon when asked, and you're also responsible for monitoring the patient. So you're like the bridge between the surgical team and everyone else who's supporting the patient.
So how did you first get into this type of nursing?
I remember one of my most formative experiences as a student nurse was shadowing a perioperative nurse in theatre. I had to scrub up too, and I was expected to lend a hand because they didn't want somebody just standing around in the way. It was all new to me, and I was worried how I'd react. I was fine around blood, but I'd never seen a wound being created before. It was a 30-minute hernia op, so nothing special, but it left a deep impression on me. Then later, when I'd reached the stage in my career where I was up for a challenge, that image came back to me.
And what sort of background do you need to go into this kind of nursing?
Well, you can do specialist courses, but I think what's crucial is having a fair amount of nursing experience, particularly in critical care settings. That was true of me, and there's really no substitute for that. To be honest, the job wouldn't suit everybody. The hours can be gruelling, and the work's very demanding. You can't just pop out to the bathroom or have a snack when you feel like it. And you're stuck in a small room with some quite strong personalities who are also under pressure. So it's a very intense environment, but also a very rewarding one.
And what skills does it call for?
Well, basically every second counts. You've got to be very efficient and able to think ahead and get things organised. You know, what needs doing immediately, what can wait a few moments, what you need to do now because you might not get the chance later, and so on. I mean, that's the kind of thing you can train somebody for up to a point. But to do it well, you've got to be in the mindset to start with. Attention to detail is crucial. If that's not how you are, then you're not going to be right for the job. You have to be there mentally 100% as well as physically.
And I guess the idea of the team is really important in theatre.
Indeed. It's got to be part of the system. I mean, especially when you're on call, you never know who you're going to be working with. For an operating theatre to run smoothly, there's got to be clear communication and coordination between everyone concerned, because it's the collaboration within the team that keeps patients alive. In my hospital, to promote team spirit, we set great store by meetings. The preoperative briefing, of course, but also meetings to discuss issues and generate new ideas. As a nurse, it's great to feel that your voice counts, and that's not always the case in medicine. So for me, that's a big plus. We also take opportunities to debrief staff after difficult events. I mean, that's crucial too.
And what about the interactions with the patients?
Well, some people have the idea that in the operating theatre you're going to be having just mechanistic interventions on patients who are in no position to respond or interact with the nurse, that you're just providing support to the surgeon and the anaesthetist. But these days, theatre nurses are required to have a holistic, patient-centred approach to care, and this extends beyond the period of the patient's actual surgical experience. Preoperative visitings become the norm, so that patients see a familiar face when they come in for treatment, and this can really reduce stress levels on the day for the patient. For me, this is a really positive development, and I'm always keen to take on that role.
Now look at Extract 2, questions 37 to 42. You hear the discussion of a physician with junior doctors on different types of hernias. You have 90 seconds to read questions 37 to 42.
Hello, doctor. Could you please explain to us about different types of hernias?
Well, inguinal hernias are located in the lower abdomen just above the leg crease, adjacent or near the pubic region. At times, they can also occur on both sides of the pubic area, which is called bilateral inguinal hernias. Inguinal hernias, along with femoral hernias, make up the two types of groin hernias and can cause pain that extends into the upper thigh or scrotum. Inguinal hernias can be categorized as direct or indirect. An indirect inguinal hernia occurs due to natural weakness in the internal inguinal ring, while a direct inguinal hernia caused due to the weakness in the floor of the inguinal canal and is more likely to develop in men above 40. The floor of the inguinal canal is located just below the internal inguinal ring. When inguinal hernias are repaired using the tension repair technique, recurrence rates may be more than 15%. However, other techniques used for hernia repair, such as tension-free and laparoscopic tension-free, have much lower recurrence rates of just 1%. A sportsman's hernia is a condition of chronic exercise-related suprainguinal groin pain. Generally, it involves a direct inguinal hernia. Femoral hernias, along with inguinal hernias, are groin hernias, which are very common in women but can occur in men as well. A weakness in the lower groin makes the intestinal sac to drop into the femoral canal, a space near the femoral vein that carries blood from the leg. These hernias are highly prone to develop incarceration or strangulation as an early complication. Incisional hernias appears in the abdomen at the site of a previous surgery that can appear weeks, months, or even years after a surgery and can vary in size from small to very large and complex. Umbilical hernias appear near the belly button or navel due to a common weakness from the blood vessels of the umbilical cord. This may occur in infants at or just after birth and may resolve by 3 or 4 years of age. However, in adults, umbilical hernias will not resolve and may progressively worsen over time. Epigastric hernias are more common in men than women. They occur due to a weakness or opening in the muscles or tendons of the upper abdominal wall on a line between the breastbone and the navel or umbilicus. Spigelian hernias, a protrusion of intestine or an empty sac through a weakness between the muscle fibers of the abdominal wall, often on the right-hand side of the abdomen. It becomes impossible to detect because often there is no obvious swelling or lump. It develops between the muscles of the abdominal wall rather than protruding through layers of fat. It often develops in later life of men and women when the abdominal muscles become weaker. Hiatal hernias are slightly different from other types of hernias because they are a weakness or opening in the diaphragm that separates the chest cavity from the abdominal cavity. These hernias cause reflux of acid from the stomach into the esophagus, resulting in heartburn, pain, and erosion of the esophagus. That is the end of Part C. You now have 2 minutes to check your answers.